Okay, future nurses, let's get right into it. I know you're feeling that NCLEX pressure, right? It feels like this giant chaotic mountain of information. Well, that's exactly why we're here. This is your high-yield power review, designed to cut through that chaos and give you some real clarity. So let's start with the question that's probably on your mind 24/7. When you're staring at all those textbooks, what are the absolute non-negotiable things you have to know to pass? That's what we're about to break down. So here's our game plan. First, we're going to decode shock so you can spot the different types in a heartbeat. Then we'll jump into the life-saving emergency interventions you've got to know. After that, we'll zoom out to look at disaster management before diving deep into pediatrics, hitting the key heart conditions and common illnesses. Let's do this. All right, first up, decoding shock. Seriously, this is one of the most fundamental things you can learn. If you can master shock, you're building an incredible foundation for handling almost any patient crisis. So what is shock at its very core? It's simple, but it's so critical. It's when the body just isn't getting enough blood flow. That means tissues and organs aren't getting the oxygen they need to survive. Every single thing you'll do as a nurse in this situation is aimed at fixing this one huge problem. Now, the NCLEX loves to test you on the different flavors of shock. These are the big four you have to nail down. You've got hypovolemic, which is all about losing fluid, neurogenic, from damage to the nervous system, and then septic and anaphylactic, which are kind of like cousins. They're both distributive shocks where the blood vessels get way too wide. Okay, pay close attention to this one because this is a classic NCLEX trap. They love to see if you can tell the difference between hypovolemic and neurogenic shock. And here's the trick. Just look at the key signs. They're literally opposites. With hypovolemic, the body's panicking, so the heart rate goes way up, tachycardia, and the skin gets cool and clammy. But with neurogenic, the nervous system signal is broken, so the heart rate actually drops, bradycardia, and the skin gets warm and dry. If you can remember that one simple difference, you've got this. So let's build on that. Now we're moving into emergency interventions. This is where the rubber meets the road, where you take what you know and act on it when every single second matters. And what's the big, flashing red light that screams shock? It's this: hypotension, abnormally low blood pressure. You'll see this across so many types of shock, and it's your signal that the body's perfusion is failing big time. This isn't just a number, it's a crisis. This slide right here is NCLEX gold. You have to know how to respond to hypotension. So what are your moves? It really comes down to two main things. You gotta fill the tank, right? So you push IV fluids like normal saline, and then you squeeze the pipes using vasopressors like dopamine to get that pressure back up. Fill the tank, squeeze the pipes. Remember that. Of course, shock isn't the only crisis out there. You've got to be ready for these too. DIC is this terrifying paradox where the body is clotting and bleeding out all at once. Then there's cardiac tamponade, where fluid crushes the heart. And you know what? You even need to know about bioterrorism agents like anthrax and smallpox. They're fair game on the exam. So when you walk into a chaotic scene, how do you make sense of it? You use this system. Triage is all about priorities, and it starts, and I mean always starts, with your ABCs: airway, breathing, circulation. After that, you find and fix whatever is going to kill the patient first. This is how you bring order to the chaos. Okay, let's zoom out for a minute. We've been focused on one patient at a time, but what happens when there's a disaster? Let's talk about the big picture of emergency response. You're going to see two key acronyms here: HICS and OEM. Here's the easiest way to keep them straight. HICS is for the hospital. It's how the hospital manages the emergency on the inside. OEM is for the whole community. Think of it as the government agency, like FEMA, managing the response on the outside. HICS inside, OEM outside. All right, time to switch gears completely. Let's talk about our pediatric patients. We're going to start with the heart and zero in on those high-yield conditions, both congenital and acquired, that you're very likely to be tested on. So first, let's just get the basic definition down. Congenital heart disease. Well, it's exactly what it sounds like. It's a problem with the heart structure that a baby is born with. It's a big umbrella term that covers a whole bunch of different issues. And under that big umbrella, here are two you absolutely must know. VSD is just a hole between the two bottom chambers of the heart, the ventricles. And PDA is when a little blood vessel from before birth fails to close up like it's supposed to. The problem with both is that they let oxygen-rich and oxygen-poor blood mix when it shouldn't. Okay, now let's talk about an acquired condition. This is something a kid isn't born with. Kawasaki disease is this really serious inflammation that is so dangerous because it goes after the coronary arteries, the ones that feed the heart muscle itself. So, how do you spot it? These are your classic signs. The number one thing is a super high fever that just won't break. Add to that a strawberry tongue, a rash, and skin peeling off the hands and feet. Your brain needs to scream Kawasaki. And the treatment? You gotta know this: IVIG to cool down that inflammation, plus high dose aspirin. Here's another really important one. For rheumatic fever, the key connection you have to make is that it starts with an untreated strep throat. That's why we take strep so seriously. If you don't treat it, it can trigger this massive inflammatory reaction that can cause permanent damage to the heart. All right, we are in the home stretch now. For our last section, let's do a quick hitter, rapid review of a bunch of other essential childhood illnesses you need to have on your radar. Let's start with respiratory. For an asthma attack, what's your priority? A fast-acting bronchodilator. For cystic fibrosis, you need to think thick, sticky mucus everywhere. Hear a seal-like barking cough? That's your classic croup. And after a tonsillectomy, what are you watching for like a hawk? Bleeding. So watch for that constant swallowing. And now for GI and endocrine. Let's make some connections. You see projectile vomiting in an infant? You think pyloric stenosis. You see ribbon-like stools? You think Hirschsprung's. Celiac disease is all about that gluten-free life. And of course, type 1 diabetes means insulin for life. It's all about recognizing these patterns. As we wrap this up, I really want you to think about this. The NCLEX isn't just about how many facts you can cram into your brain. It's a test of pattern recognition. Can you see the clues that point to Kawasaki? Can you spot the subtle differences between two types of shock? That's the skill that truly matters. So I'm going to leave you with this final question. When this exam is behind you and you have that nursing license in your hand, how are you going to take these ideas off the screen and bring them to the bedside? How will you connect all this knowledge to a real, live human being, your very first patient? Because that's what this is all about. You can do this. You've got it.